which is tonight we are not diving into the glamorous world of ACL reconstruction or shiny new total knees. This is kind of the down and dirty reality of orthopedics, stuff like the wrist. In fact, the humble fall on an outstretched hand, which is something that we will all see again and again and again in a career if we truly follow orthopedics. But the fun thing that I can promise tonight, at the very least, is that if you can wrap your head around the anatomy that we're going to cover, it'll pay off in some really important ways. For OMS-Is, I mean, this is literally on your upper extremity exam later this month. And although we're going to go way further into depth and nuance compared to what's going to be on your exam, it'll give you an introduction and an approach to anatomical thinking that will serve you well. And then for everybody else, I mean, knowing even 10% of this would make you look scarily well prepared on rotations. And for all of us, I mean, this is the reality of how orthopedics works. I mean, connecting anatomy and exams and imaging and management, and then innovation at the very end. So again, not the flashiest of injuries, but I promise you, this is the stuff that makes you look like you belong in the OR, in the clinic, from day one. So without further ado, I'm going to hand it off to Raman here, who's going to take us through some of the learning objectives for the day and some surface anatomy, and start with like some basic wrist biomechanics.
Hey everyone, hope everyone's doing well today. All right, so we're just going to talk about why is this topic important. So today we're going to talk about three major wrist pathologies that are not only very common in clinical practice, but also frequently tested on exams. So we have scaphoid fractures, TFCC injuries, and Kienböck's disease. Let's start with scaphoid fractures. So these are going to be accounting for 70% of all carpal fractures, making them by far the most common. So the big concern here is the risk of non-union if the injury is missed. So you may be thinking, why is that? The scaphoid has a unique retrograde blood supply, meaning blood enters from the distal end and flows backward towards the proximal pole. So if the proximal pole is fractured, the blood supply can be cut off, leading to avascular necrosis. Clinically, scaphoid fractures are disproportionately tested because they bring together everything, surface anatomy, mechanism of injury, like if you fall on an outstretched hand, also classic exam findings such as stuff box tenderness. And then we all have when it comes to the orthopedic side of things, there's these pitfalls of imaging and management decisions. If a fracture persists for more than 6 months, we call that a non-union. And that's a real issue. Up to 30% of scaphoid fractures are initially missed on plain x-rays, which sets the stage for degenerative diseases that can eventually progress into scaphoid non-union advanced collapse. And then on the orthopedic world, they call that snack wrist. So this is why scaphoid fractures are considered bread and butter pathology for every orthopedist. And so first, we're going to get into this figure on the top right, and that is a MRI showing a dark signal in that scaphoid bone, which tells us blood flow is compromised. And after that, we're going to get into some TFCC injuries. So let's focus on these TFCC injuries. That TFC term is known as triangular fibrocartilage complex, but we're just going to refer to it as TFCC because it's a little bit faster. So these account for 3 to 9% of all wrist injuries and are especially common in athletes who load their wrists axially, like tennis players, gymnasts, or even baseball players. The TFCC is the main stabilizer of the distal radial ulnar joint, and when it's injured, there's a classic symptom of ulnar-sided wrist pain. On exam, patients may show fovea tenderness or have a positive TFCC compression test. There's a classification system called the Atzei classification that breaks down peripheral TFCC tiers into 5 categories, which if you guys look to the left, we can see there's those 5 pictures going up to down. So Class 1 is a distal tier with the proximal portion intact, and this is repairable. That's that first picture. Class 2 is a complete tier, both distal and proximal portions torn. Class 3 is a proximal tier with distal intact, which is also repairable. Class 4 is non-repairable with both proximal and distal torn. Class 5 is arthritic, and outcomes can vary. This classification is important because it guides treatment decisions. So that's the key takeaway. Kienböck's disease, let's talk about that. This is simply avascular necrosis of the lunate. We call it Kienböck because it has a formal staging system that helps drive treatment decisions. The disease has it has multiple strong associations with negative ulnar variance, meaning the ulna sits shorter than, it's just slightly shorter, but it sits shorter than the radius, as well as prior trauma can, give you that negative ulnar variance. And it's most often seen in young adults and can progress from subtle sclerosis of the lunate to full-blown carpal collapse if it isn't treated early enough. And then on exams, you'll often see questions that can test your ability to recognize these risk factors. And so this figure on the bottom right, it's on the left side, you can see that the lunate looks darker than normal, showing sclerosis. And on the right, there's contrast, and it doesn't light up at all. So that's a classic sign of no blood flow. All right, and just to summarize that previous slide real quick, scaphoid fractures are the most common carpal fracture with high risk of nonunion, and TFCC injuries are the classic cause of ulnar-sided wrist pain, especially in athletes. And Kienböck disease is avascular necrosis of the lunate, strongly tied to ulnar variance and trauma. Together, these are going to represent some of the most important risk pathologies that every orthopedist must know, both for clinical practice and for exams. And now that we've established why these risk conditions matter in the first place, let's talk about how we'll approach them today. So we'll begin with our roadmap's going to mirror the way surgeons actually think. So we'll begin with anatomy, and then that'll lead into pathology, because it's the blood supply and ligament stability that explain why these injuries become such a problem. For example, the scaphoid's retrograde blood supply make the proximal pole vulnerable to necrosis. The TFC's foveal ligament insertions are what give the distal radial ulnar joint stability. And in Kienböck disease, the lunate's role in load sharing helps explain why collapse patterns develop once its cartilage and vascularity fail. From there, we'll move into imaging. This sits at the center of all three conditions, but it's not straightforward. So MRIs can offer high sensitivity for early pathology. CT gives unmatched bony detail, and arthroscopy still remain the gold standard for diagnosing and sometimes even treating the wrist injuries. The debate here is really which modality gives you the best and most actionable information in each case. And next is management, and this is where the controversies begin. So should we treat non-displaced scaphoid fractures in a cast or fix them surgically with screws? And for TFCC injuries, should we perform an open repair or use arthroscopy? And for Kienböck, should we focus on unloading and revascularization in the early stages, or should we move toward salvage procedures like proximal row carpectomy or partial fusions once collapse has set in? These are real debates with no universal answers. Then we'll look at innovation. Advances like 3D printed patient-specific surgical guides are changing how we approach scaphoid non-union. New classification systems like the CUP classification for TFCC lesions help us refine diagnosis and new treatment. And even Kienböck disease is being reframed with models that combine vascularity, cartilage, and bone health to all into a single system. Finally, we'll close with research opportunities. Despite how common these injuries are, there are still clear gaps in the literature. We yet don't have strong comparative trials between open and arthroscopic TFCC repair or long-term data on 3D printed guides for scaphoid reconstruction. Even better prognostic imaging for Kienböck remains an open question, and these gaps are perfect spaces for students and residents to explore, whether through literature work or future clinical projects. Now that we've framed this big picture, let's look at how surface anatomy helps us pick up these risk pathologies, and they're going to be right at the bedside. So first, let's talk about the snuff box. When you extend your thumb, a small triangular hollow appears between the extensor pollicis longus and extensor pollicis brevis tendons. The scaphoid sits right underneath. So here's the classic question. If patients fall on an outstretched hand and has tenderness here, what should you think of first? Well, the answer is scaphoid fracture. Even if the x-ray looks normal, you must treat it like a fracture until proven otherwise. Why? Why is that the case? Well, because the scaphoid's fragile retrograde blood supply, because of its retrograde blood supply, the risk of avascular necrosis is just way too high to ignore. Next, the distal radial ulnar joint, or often called drudge. This joint is what lets you turn the palm up and down. So its key stabilizer is the TFCC. And how do we test it? Well, at the bedside, we can use piano key or ballottement tests. If positive, they strongly suggest TFCC injury. And yeah, we'll talk a lot more about these a little bit later. So let's finally talk about the ulnar side of the wrist. This is where things get a little bit interesting. There's a small spot between the extensor carpi ulnaris and flexor carpi ulnaris tendons called the fovea. Tenderness here can mean a TFCC tear, or a ulnar triquetral ligament injury. But if the pain localizes right over the lunate bone, that will raise more suspicion for a Kienböck disease, or lunate avascular necrosis. And so if we look over here on at figure 1, we can see that that's exactly where the ulnar-sided pain localizes. And then we're going to get into some wrist biomechanics right here. Since we've grounded ourselves finally into the clinical importance of scaphoid fractures, TFCC injuries, and Kienböck disease, let's take a step back and let's ask, what are the mechanics that make these injuries so consequential? For the scaphoid, let's think about it like this. The carpus, let's think about it as two stone arches, the proximal and distal rows. The scaphoid is the keystone linking them. If it breaks and heals out of alignment, the entire arch twists and collapses. What's the downstream effect of this? Well, predictable patterns of carpal collapse and arthritis, and then that's what we call snap wrist. So this is the importance of this, right? Surgeons obsess over this because it's not just about fixing the fracture, but restoring its precise shape. Next, we'll talk about the triangular fibrocartilage complex. This TFCC is a primary stabilizer of the distal radial ulnar joint, especially its deep foveal fibers. I like to call it the seatbelt of the ulna. The seatbelt of the ulna, because it anchors the ulnar head to the radius during pronation and supination. So without it, this ulna is going to ride loose. And every twist of the forearm becomes unstable pretty much. And here's a critical biomechanical point that's very important. It carries about 20% of axial load through the forearm. So a TFCC tear isn't just about the pain. It's kind of like a double hit. You lose stability and improper load, then there's going to be improper load distribution. Finally, we're going to get into ulnar variance. A smaller difference in ulnar length, and it can even be up to like 2 millimeters, reshapes how forces are transmitted across the wrist. A positive variance means a longer ulna, and pretty much what's going to happen then is the TFCC and ulnar carpus are going to become a lot more overloaded, and that's going to set you up for tears and impaction. A negative variance, which is a shorter ulna, unloads the TFCC, but it's going to put excessive stress on the lunate. And that's why negative variance is a major risk for Kienböck disease. So the ulna is like I like to say it's like the adjustable leg of a table. If you raise it or you shorten it just slightly, then suddenly the load is distributed in a completely different way. So when we talk about anatomic reconstruction, this is what we mean. Keep the scaphoid aligned, preserve the TFCC's seatbelt function, and account for ulnar variance. Only then do the arches stay balanced. the seatbelt stay intact, and the wrist maintain its remarkable range of motion. With that foundation in biomechanics, I can now hand it to Jack to dive specifically into the scaphoid injuries.
Okay, so again, as we've talked about a little bit already, 83% of the blood flow to the scaphoid bone comes from the dorsal radial artery, enters distally, and travels proximally, which you can see on that bottom left diagram there. Again, basically just flowing backwards towards that proximal pole, which will be something we talk about a lot. So because the blow has to flow retrograde, the proximal pole is the furthest sourced and is thus most at risk for avascular necrosis. The distal pole has a separate, kind of more direct blood supply, so these fractures typically heal without major problems. So the clinical implications of this is that about 5 to 10% of scaphoid fractures don't heal, and this risk obviously increases significantly for proximal fractures due to that poor blood flow. If blood flow is preserved, surgeons can usually fix it with screws and a regular bone graft, which will generally heal quite well. But of course, if blood flow is compromised, they need to bring in a graft that already has its own blood supply, a vascularized graft. And even still, healing is harder, and only about half of those cases fully unite. So this missed fracture potential. This is kind of your classic snuff box tenderness plus normal X-ray is never ignored. A missed fracture can progress to snack wrist with predictable arthritis and potentially permanent wrist deformity. Okay, so I already talked about the Fouche fall. Raman took us through that. But it's, again, important to highlight the prevalence of this and how common it really is in really just about anybody, especially young adults or sports injuries. So usually this classic fall is characterized biomechanically with the wrist extended, radially deviated and pronated, which places the scaphoid center stage to absorb the axial load from the radius and concentrates the stress at the waist, which is the middle of the bone, or even the proximal pole. There's some wrist biomechanics up at the top right. And even again, 5 to 10% overall non-union despite treatment. So even with early management, 5 to 10% of these acute scaphoid fractures will progress to non-union, with that risk increasing, again, if diagnosis is delayed or inevitably it's inadequately immobilized. And like I mentioned a moment ago, normal avascular necrosis risk is only about 1% on average, but up to 40% in proximal pole fractures. In unstable waist fractures, which is again the middle of that scaphoid bone, the distal fragment flexes while the proximal segment extends due to that opposing ligament force, which creates something called a humpback deformity, which again further alters carpal alignment and mechanics. And we won't really go into that today. Some of the articles on that are really complex physics. But again, the progression to snack risk, we already discussed, and it's really just, again, important to notice that this can start arthritis that can begin at that radioscaphoid joint and inevitably progress mid-carpally. Okay, so let's do like the quickest of check-in really quick. Why don't I actually... So, just thinking out loud, because God knows I can't monitor the chat anyway. And don't worry if you don't know, that's why we're all here. Which imaging modality gives us the cleanest bone structure and fracture shape, and which one tells us the most about blood supply? So just think really quickly, what do you know about imaging?
Jack, there are some people in the waiting room. Sorry.
Yeah, let me see if I can snag them really quick while y'all are thinking anyway. Oh, wait, that probably gave away the answers, though. Okay. Sweet. Okay, well, that gave away the answers. That's all right. So again, bone structure and fracture shape, CT, and then blood supply, MRI. And if you definitely got some extra points if you realized with contrast, which we'll talk about a little bit more in a second here. So X-rays they're always just going to be your first line. It's a plain radiograph. It's a first step because they're fast, they're accessible, but they can miss up to 1/3 of acute or non-displaced fractures. And early films might even look normal when a fracture is present. Later changes like sclerosis aren't specific. They might mean healing. There might be some necrosis or just disuse osteopenia, which is why a normal X-ray never fully rules out a fracture. That's definitely one of the key things today. For CT, it's best for seeing the fine details of bone, fracture lines, displacement, comminution, that humpback deformity I talked about. And it's also really good for evaluating graft integration after surgery or even preoperative planning, since it shows angles and lengths really well. And then MRI is definitely the most reliable tool for assessing blood supply. We've seen a lot of T1 images with avascular necrosis that shows up really well in that proximal pole. And then if you add in contrast, you get from like 36% sensitivity to between 63 and 66%. An MRI can't perfectly predict healing, but it's definitely the best pre-op tool for deciding whether or not we're using a non-vascularized or an actual vascularized graft. And then the clinical implications, pretty straightforward. Radiographs are always first line for a reason. But if you see snuff box tenderness and you have a normal X-ray, you don't stop there. Then the CT can give you a better bony map where the fracture is, if it's collapsed, things like that. And then the MRI lastly answers that vascular question, is that proximal pole alive? And that helps you determine what you're doing with the graft. Okay, it's kind of the fun part here, the actual how we're fixing it thing. So when we're talking about acute non-displaced scaphoid waist fractures, again, the middle of that scaphoid bone, both cast immobilization and percutaneous screw fixation both achieve very high union rates. There was, in fact, a really big meta-analysis that showed there wasn't really much of a statistical difference between them, which means the choice of treatment between those two really isn't will it heal. It's more about how quickly and at what risks. So we've discussed displacement, proximal pole location, or poor vascularity are definitely the factors that do drop union rates. But between these two methods, we're really talking about favorable outcomes in both. So it becomes much more about the patient. So this is where differences do start to show up at least a little bit, which is that pooled data suggests between like 11 weeks for a cast and like 7 to 8.5 for screw fixation, which means you're shaving like 3 to 4 weeks off a healing timeline, but there's other things implicated. For many patients, this can mean earlier progression to rehab, clearance for higher demand activities, which could matter for your athletes, or again, missing part of a season or work time for certain people. And from a functional standpoint, return to work is usually your patient's top priority, unless you are working with athletes or some other population. The data does show, though, that screw fixation patients get back to full duties about a month sooner, due in part to shorter immobilization and the stability that that screw, as you can see in that photo, it definitely provides some stability. But keep in mind that type of work matters. A desk worker might not gain as much benefit from this as much as like a construction worker. There are complications, though. The overall complication rate for both is quite low nowadays, with orthopedics where it is as an industry. But cast complications usually are much milder, like some stiffness, some occasional delay union, but they're usually very, very not catastrophic injuries. Screw fixation, on the other hand, while again not common, can be more severe. That hardware can be malpositioned, the screw can loosen, you can get an infection, or again, you can create avascular necrosis from the screw itself. So that's kind of the trade-off. Faster recovery potential versus higher risk of a bigger problem if anything does actually go wrong. So when do we kind of favor each? So casting is a great option when time to recovery doesn't matter. Think older adults, office workers, anyone who just wants to avoid surgical risk in general. And it's a safer choice for patients with comorbidities that might actually increase surgical risk, or those who might be unlikely to adhere to post-op restrictions. And then the screw option is great for job or sports performance, but depends on wrist strength and mobility, or for people, I'm sorry, who depend on wrist strength and mobility as soon as possible. That screw fixation offers a clear advantage in terms of functional timelines. It's also useful for patients motivated to comply with close follow-ups and early rehab. And this is kind of the important part. I mean, this is a shared decision between you and your patient. And be transparent. I mean, don't just give them the data. You can talk to them about which option might be better for them. Do they care about mild stiffness versus the risk of surgical complications? Patients should understand, and again, not only that percentage risk, but the impact if it does happen. Lifestyle and work demands. I mean, try to match the treatment to the patient's daily functional needs. It should be obvious that an athlete and a retiree might have very different priorities. And then follow-up compliance, something that's, again, really important for us to physicians to know. Screw fixation patients need reliable follow-up and wound checks, while casting patients just need some monitoring for union, and there's way less moving parts in aftercare. It's much more straightforward. Okay, so if we do progress to scaphoid non-union, has already been kind of touched on, CT gives us the clearest picture of that scaphoid anatomy, including the fracture line. You can check for the collapse or misalignment of bones. And a really thin slice CT is kind of the gold standard for evaluating the shape and position of fracture fragments before you go in for surgery. On MRI, viable scaphoid bone looks similar to muscle. So that's again why we go with that gadolinium contrast to help really picture blood flow and visualize a pattern that supports good healing potential and the potential sustainability of a non-vascularized graft. So in general, when you're looking at MRI, which you guys have already seen a couple shots of, if that bone is lit up, you can tell that blood flow is getting in there. Then step two, if that proximal pole looks good to go on T1 and with enhancement, it suggests it's pretty well perfused and you can kind of rule out avascular necrosis. If T1 is dark with no contrast uptake, then that's probably avascular necrosis. Non-contrast hypointensity is extremely specific, so you can definitely trust it. It's not very sensitive, meaning some cases can still look normal, but in practice, T1 is your rule in, and gadolinium contrast is sort of your rule out. Once you've done that, you can select your graft. If you're looking good on the vascularity front, then a simple graft from like the iliac crest or the distal radius, plus a screw fixation heals pretty much every time, and you don't really need to complicate it. The saying that I've heard in orthopedics is if it bleeds, NVBG succeeds, which is non-vascularized bone graft. So again, kind of keep it simple. So if you are dealing with avascular necrosis, then you're going to need to figure out how to get a vascularized bone graft, which is usually something where you harvest a piece of bone with its own artery. That's the shot there. For example, the distal radial pedicles, where you bring in some living bone to reperfuse the necrotic pole. And then, I mean, if you have severe deformity plus avascular necrosis, when you have both collapse and blood loss coexisting, you need a graft that definitely restores both natural shape and flow. And this is where something like a medial femoral condyle graft can be contoured to actually rebuild scaphoid length while also simultaneously revascularizing it. Okay, and then this part's really cool. This is, again, the world of orthopedics that we're all going to kind of walk into here in the future. So 3D planning. So these are the toughest cases. This is where the bone is misshapen or shortened or again has the poor blood flow. In revision cases or deformity with AVN, freehand surgery would be like eyeballing a 3D puzzle with missing pieces. So in this case, 3D planning with patient-specific guides provide a custom fit template that can restore normal shape and improve union rates. CT data can create a virtual mirror of the patient's healthy scaphoid, and this can let the surgeon kind of pre-plan how they want to move fragments around and exactly where to place the grafts. And the printed guide can then lock onto bone in surgery like GPS and kind of ensuring cuts and drilling follow a very pre-planned path specific to that patient. So the evidence so far on 3D planning is that a large case study showed 92% union in primary reconstruction, and even more importantly, 87% in revisions after failed fixation. And these numbers are on the way high end of expected outcomes, showing that PSGs maintain success even in really difficult settings. One of the articles I found worked with computer models and prints to plan surgery, and although it was only 7 patients, all of them united. So with scaphoid, scapholunate and radiolunate angles restored close to normal. And again, as we've talked about, the alignment really matters because it preserves wrist biomechanics and delays the arthritis that can come with it. There was also a meta-analysis that showed that PSGs can shave off 17 minutes from operation, which is great. That means less anesthesia time, a lower peri-op risk, and more efficient use of the OR, which is always linked to cost effectiveness and patient safety, which is things that surgeons love. Are some limits and barriers though. There are some case series and cohorts, but there's no massive random controlled trials. So far, most studies are just kind of small and single-centered reports like that one with an N of 7 that I mentioned, which are promising results, but still kind of low-level evidence that don't really lend itself to PSGs as the gold standard quite yet. They do cost like $400 to $500 per guide, which I know doesn't seem like a lot, but for certain hospitals with like limited resources, that is something to consider. And the process does need a CT scan, some software, and some printing, which is, again, more infrastructure. It also adds some prep time, so you can't really use it in emergency settings. So right now they are a tool to improve surgical precision, but not necessarily a guaranteed outcome or something that everybody's going to use. And again, this is an example of something different. This wasn't exactly what I was looking for. I couldn't find one, but it gives you kind of an idea of the model that you would get. Okay, so then switching gears here to TFCC. So this is the central articular disc. We can kind of think of as like the meniscus of the wrist. It kind of cushions the joint. The dorsal and volar radial ulnar ligaments are the main drudge stabilizers. And again, kind of like the seatbelt analogy used earlier, they kind of keep the distal radius and ulna moving together. Um, a meniscus homologue, the ulna triquetrum soft tissue bridge, is like a very small soft tissue connection between the ulna and the triquetrum, and it again helps with stability. And it kind of tethers the ulna and the lunate and triquetrum all together and just adds more stability to the wrist. The ECU subsheath is the sheath around the ECU tendon that ties into the capsule. And again, all of this serves to just kind of stabilize the joint. So what this matters in vascularity is that peripheral tears at the edge, they luckily have blood supply and have a higher chance of healing, kind of like that distal pole of the scaphoid. However, the middle has no blood supply. So tears here really don't heal. And you usually go with a process called debriding in this case, which really just means tearing away the torn, frayed tissue so it doesn't catch on anything during movement or cause any pain to the patient. So since central TFCC has no blood supply, if it can't heal, even if you sew it up. So surgeons usually just clean it out, smooth up the surface, and that usually relieves symptoms without making the joint unstable, which is again a key piece here. And then lastly, those foveal fibers are critical. If they're torn, then we're just going to get instability. And about a fifth of the force through the wrist goes through the TFCC, like Rahman said earlier, and it absorbs a lot of stress when you bend the wrist towards the ulna. So in general, important takeaways here are just that central disc tear won't heal, has no blood supply. However, peripheral tears will, and it's a really, really important piece of stability. I'll just blaze through some of these classification systems really quick. But the Palmer system is the classic system. It's just a really good starting point. It separates traumatic tears, which are type 1, from degenerative wear and tear lesions, which are type 2. And again, remembering that central tears are avascular, usually get debrided, while peripheral traumatic tears are usually capable of repair. And then the Atzei peripheral refinement scale that was mentioned earlier kind of just builds on the Palmer by zooming in on those peripheral tears. If the foveal insertion is involved, the drudge becomes unstable and definitely needs some repair. Distal lamina only tears are usually more stable. And then lastly, the newest system is the CUP, which is designed for MRI and arthroscopy. So that maps lesions more precisely to that central disc, ulnar insertions, or peripheral capsule ligaments, and has a severity grade. And of course, these are all good independent systems. You can use all three depending on what the injury is. All right, imaging. So, MRI strengths. MRI is really good at picking up central TFCC tears. Sensitivity and specificity are both really high, between 90 and 99%. In most studies, it's non-invasive, again, widely available like we talked about, and is usually that first advanced image testing that's ordered. Does have some limits though. The problem is that MRI isn't reliable for foveal or peripheral tears, which are exactly the ones that can actually cause that instability at the drudge. And sensitivity can drop around to 85% or really even lower in some studies. So MRI can't really show dynamic instability. So a patient can have a normal MRI but still have a pretty clinically significant tear. What we'd like to do for most of the time is an MRCT arthrography, which is when contrast is injected into the joint, and subtle peripheral or foveal tears become much easier to visualize. And then that improves our accuracy up to like the 80 to 90% range for some of those trickier lesions. So some centers still use MRI if it's inconclusive. But of course, arthroscopy is always your gold standard. In so many other cases outside of just the wrist, it beats every scan because it lets the surgeon look directly at the TFCC, probe the tear, see if it's causing instability, and of course you're already in there, so it's therapeutic. So if a tear is found, you could do debridement or repair literally in the same sitting. And then the question always becomes, when are we going to scope? When should we go for the arthroscopy? So if patient has already ongoing ulnar-sided wrist pain, positive instability signs on exam, or a high suspicion despite a clean MRI, that's when you scope. And the scope is going to give you that definitive diagnosis and again, the chance to just fix it right then and there. Okay, TFCC repair. So arthroscopic versus open. Both arthroscopic and open repairs get patients to the same place after about 2 years. So good pain relief, improved function, stronger grip, kind of all the stuff we're looking for after a wrist injury anyway. The big difference is early motion. Again, for a lot of other things in orthopedics, this is true. Arthroscopy is less invasive. So patients regain the ability to move, in this case, pronation, supination, and flexion extension, on average 2 to 4 months faster. That matters most for athletes or people who can't afford to sit through a really long, stiff period of recovery for whatever reason. Then we look towards suture anchor and transosseous. Both improve pain, function, and grip strength, and again, low re-op rates, and reliably improve all of those. I don't want to bore you with the details of the DASH and the PRWE systems, but the disability, the arm, shoulder, and hand, and patient wrist evaluation, both techniques just improve patient-reported less pain outcomes and better function after surgery, which is stuff that we care about. Like usual, though, what we're going to make this decision based on is complication patterns. SA has a higher rate of neuropraxia, usually temporal nerve irritation, which can be scary. And then TOS avoids that, but has more knot irritation, and up to half the patients feel knots. And some of those can require another arthroscopy, another removal. So in this case, no method is clearly superior. It's kind of more about surgeon comfort and which they're more comfortable with. And then lastly, looking at athletes specifically, in central palmar 1A tears, where we have an avascular disc, they're debrided rather than repaired, so that return to play is really quick, like 4 to 6 weeks for low load sports, or maybe only 6 to 8 weeks for like a racket sport. Peripheral and foveal tears need repair because they affect stability. So again, that means like 4 to 6 weeks of immobilization and then at least 6 to 8 weeks of rehab, which means your return to play or return to work time is more like 2 to 3 months. So really all of this summed up, the clinical pearl is arthroscopy is often chosen mid-season because it allows faster recovery. A lot of athletes get this injury repaired arthroscopically. But if stability is compromised, you can't shortcut biology. Repairs do need time to heal. Okay. So injury patterns. When the wrist is loaded while rotating, like tennis, golf, baseball swings, the TFCC takes the hit. This is why these sports are classic, and you also see it in gymnastics or volleyball, where the wrist is repeatedly jammed into extension with force. Again, return to play is always something we're thinking about. If it's a central disc tear, you can clean it up with a scope. Recovery is fast. Light contact, like ball dribbling, you can get back to even within like 3 weeks, and most load sports within like 4 to 6 weeks. Foveal tear, those peripheral tears, means we're actually reattaching the ligament to the drudge. That requires some level of protection. We might need to do like 4 to 6 weeks in a cast, another 6 to 8 weeks of therapy. So again, this is tough for an athlete because this might mean like 2 to 3 months off. However, because they're athletes, sometimes they might delay surgery to finish their season if the joint just feels stable to them. They'll brace, tape, inject with steroids or some other pain reliever just to get through. Make considerations based on whether or not it's their dominant hand or their throwing arm. Because again, obviously a pitcher's timeline might be longer than somebody with the same injury on their non-dominant arm. So these are all considerations we take into account when we're talking to our patients. And with that, I'm going to hand it off to Jasmine.
Hello, everyone. I am going to talk about the Kienböck disease. And like you guys previously mentioned, it is an avascular necrosis of the lunate, and this will cause the lunate to collapse, alter your carpal mechanics, and ultimately leads to arthritis. I wanted to note that Kienböck disease is actually a fairly new disease that was discovered in 1910 by someone named Kienböck. So who's at risk? Those with ulnar variance. Earlier we talked about shorter ulnar will lead to increased lunate load. So those who have this would have an increased chance of getting this disease. And then briefly, just to mention, lunate gets blood supplies from both the palmar side and the dorsal side of arteries, and they're both supplied by radial artery and ulnar artery. So some people may have anatomic variants where they only get one set of blood supplies, so those will have a higher chance of getting this disease. Others include those with lupus or systemic conditions, history of wrist fractures or trauma, and then people who are Caucasians are more likely to get this disease. But however, male versus female, there's not really any differences. So presentation-wise, earlier patient might come in present with dorsal wrist pain, swelling, decreased grip strength. And later on, when they come in, they will have, degenerative arthritis, lunate collapse, and sometimes even malignancy for this bone. And then clinical takeaway is, before we move on to my other slides, is that catching it early will help preserve the lunate. However, if you miss it, you might have to take out this bone, and this could also lead to arthritis. So classically, the most widely used classification is Lichtman. However, there are other different categories of naming this disease. There's the Bain scale and also the Schmidt scales. I'll just focus on the Lichtman. So you see that there's stage 1 versus stage 4. Stage 1 is considered to be normal, less severe, but stage 4 is severe side. So based on the pictures on the right. And then, so for early disease, so if they're in stage 1 or 2, the lunate is still intact. So the goal is to preserve and revascularize. I wanted to note that right now, currently there's no really curing this disease. It's only helping to slow down the progression or to help reduce pain. So if you have a stage 3A or 3B, this would consider intermediate. In these stages, the lunate is collapsed, but the carpal cartilage are still able to be salvageable. So the main goal in these stages is to maintain the carpal mechanics and bypass the lunate to try to still keep your wrist functions. And the options for surgeries right now, there's something called proximal row carpotectomy. We'll touch base on this, but just wanted to give you that as an option. For advanced disease, the goal is to provide pain relief and salvage as much as you can. At this stage, the arthritis has spread beyond the lunate, and patient will be in severe pain. So in early stages, you can expect near normal function if treated, or if you wanted to choose the observatory options for children, that's still totally fine. However, if it reaches this stage where the lunate is collapsed or arthritis developed, the disease is irreversible and the motion preserving options is very slim. And then for the imaging choices, Lichtman really likes to use the CT because CT is fast and it's cheap. So on CT scans, you will see brightness because the bone is more dense because it lost the vasculature. Others, such as Schmidt, would like to use MRI. Mainly Jack touched based on this. It would appear dark because they lost the vasculature. Okay. So for Kienböck's procedures, age matters. So if you're a child, usually at this stage is observatory and no surgery is required. But if you're an adolescent, it's usually to treat the symptoms because you do have a lot of pain. But when you get to 65 and older, surgery is usually considered. When the disease is only limited to the lunate, and depending on the stages of the disease, surgeons usually, think about trying to salvage this versus not salvage the bone, taking it out completely. So this would requires imaging. But later on, if the lunate is no longer able to be preserved, surgeons tend to take out this bone completely to preserve to prevent the arthritis spreading. So like I touched base on, the most common salvage procedure right now, it's the proximal row carpotectomy. So if you look on the right side, the bottom, you see this proximal row of bones. The surgery would actually take these bones out completely. So think about it. You would lose so many of your carpal bones because they're gone. Anyway, so other surgeries, there's core decompressions that surgeons like to use. There's implants, like Jack said earlier about the 3Ds. Those are also something that in the future we can use to help preserve this bone. However, there's a lot more new surgeries that's coming out. While I was doing research on this disease, there's actually surgeons in Australia who would break the radial bone a little bit to help to push more blood to the lunate. So that's another way to preserve this bone. The proximal row carpodectomy surgery helps preserve the motion and provide pain relief without full wrist fusion. So again, just to summarize, so if you have an early stage, the surgeries would help with pain relief, preserve motions. If you're in mid stage, pain relief likely, but moderate motion loss or risk of further collapse. And in the late stage, it's pretty much you lose a lot of your functions for grip strength, able to move your wrist. So catch it early, you're able to preserve motion. Late stage, you're just trying to relieve the pain. So moving forward for future directions, it is researchers and surgeons want to look at ways to restore lunate bone instead of salvaging it. So if you look to the right, you see how the blood vessels, yeah, so this is just a summary of the blood supplies. However, so these are some of the future directions that people are trying to look at, researchers. Advanced imaging, so these surgeries will primarily be more personalized instead of just taking the bones out completely. Others wanted to look at biological regenerative approaches, such as looking at stem cells or bone marrow grafting to see if you can just restore lunate. Others wanted to look at minimally invasive techniques, meaning just to try and decompress the lunate to help release some pain. 3D printing is something that you wanted to look at as well because it will provide just more personalized approaches. And then motion preserving salvage is something that they want to, I saw the question. Yes, they're essentially trying to break the macrofracture. So they want to break the radial bone, so it helps the blood flow go towards the lunate. But yeah. So the take-home message here is that early innovations are promising, but evidence is very limited. You want to, when you're thinking about these orthopedic surgeries, you really want to look at your anatomy, use imaging, and also use the classifications to help making your decisions on what is the best approach for your patient.
Okay, and then I'll just blaze through this final little bit here really quick for us. So union rates. For non-displaced, it's like 100% for both. Both options work. Almost every non-displaced scaphoid waist fracture heals. So when we get to healing versus with a screw fixation, it's usually 4 weeks faster. The difference is really about speed. Screw fixation gets people back to work, and sports about a month earlier. Casts have fewer but more mild problems. I mean, most of us have probably been in a cast. We probably know that. And surgery has more complications overall, and they usually are more serious, like hardware issues. When we're talking about TFCC, MRI versus arthroscopy, MRI is good at spotting central TFCC tears, but not as good at foveal tears, which are the ones that actually cause instability. When we add in some contrast, some arthrography, it improves accuracy, especially for peripheral and foveal tears. And at the end of the day, arthroscopy lets you see the tear directly and fix it right while you're there. It's something we should all get used to as our future as orthopedic surgeons. In Kienböck, PRC, good pain relief, preserves 60-80% of the motion, but you risk arthritis later. Usually helps pain and keeps the motion. But again, you trade off that with the potential for arthritis. And fusions, again, trade off motion for stability, but sometimes the bones don't unite and it has some other issues involved. Total fusion, total wrist fusions take away all wrist motion, but reliably relieve pain, especially for heavy laborers. And then arthroplasty again, motion, wrist replacement can preserve motion in select patients, but implants don't last forever, and it's definitely still a new technology. So these debates don't have one right answer. Depends on the patient's priorities, pain relief versus motion, the accuracy of the imaging you're using, and of course the surgeon's experience and choice. Take-home messages, snuff box tenderness and fall on an outstretched arm. If someone falls on an outstretched arm and their snuff box hurts, assume a scaphoid fracture until you are proven otherwise. Use a CT to check if the bone has healed or is lined up right. use an MRI to look for dead bone, which is again low signal on T1, which gives you that high suspicion of avascular necrosis, especially if a proximal pole fracture. We know those are the most dangerous. If you miss that, that can progress to snack wrist and eventually arthritis. For TFCC, tenderness in the spot between the ECU and the FCU tendons usually means a peripheral or foveal TFCC tear. Start with an MRI, use some contrast. It will help you be a little more accurate in figuring out exactly where that tear is. Use the Palmer system for central tears. Peripheral tears usually get repaired. If you miss that peripheral tear, then you are risking instability. And lastly, with Kienböck, if it's a young patient with wrist pain, weak grip, and a short ulna, think about Kienböck disease. That should be your red flags. Plain X-ray can be normal early, but MRI picks it up with low T1 signal in that lunate bone. Use the Lichman scale, which can help drive your decision making, especially because early stages it can be unloaded or revascularized. While in those late stages, it might just be salvage, PRC, or fusions. And the earlier you can catch it, the better chance you can avoid that collapse or arthritis. So, a couple things that have kind of come up as potential options that we could do some research on. One, we could ask, like, well, does MRI actually match what surgeons see in arthroscopy when classifying TFCC tears? This could be a prospective study. We could see if we could follow some patients, looking at some primary outcomes like, what radiologists see on MRI and what surgeons actually confirm once they scope it. Feasibility wise, I mean, it's doable for students. However, it's going to be a ton to actually get data from, which is more than possible, but it's tough considering you need to actually get surgeons and radiologists to be willing to give you their information. And so far in the Orthopedic Journal Club, we've been way more focused on just doing actual reviews of literature. So in which case, something like option B, where we're just looking at, how effective are these 3D painted, 3D printed patient-specific guides? Are they worth the cost? I mean, again, we all saw $400 or $500, and we probably assumed in our head that, yeah, I mean, that seems like it's worth the cost. So could we develop like a desk-based model or a decision tree that actually looks at the perspectives for a patient or an insurer? Obviously, the main outcome in that would be like incremental cost effectiveness ratio. I mean, is it useful to use PSGs in most cases? We could probably try to pull some effective data from some published studies, combine it with local hospital cost data. It's definitely student friendly because it's entirely desk-based. We'd be able to abstract the literature, plug data into the model, and run some sort of sensitivity analysis. So both are potentially realistic. Again, option B develops a healthy economic skills test, and a new 3D guide tech is financially justified, and it's very new technology. Outside of that, I think I'll probably like send out an interest form because I didn't stick a non-functioning QR code at the end of this slide like I did last time. But otherwise, I appreciate you guys all sitting here through, again, like I said at the very beginning, something that's not quite as sexy as a brand new knee, but we're all going to see people who fall on an outstretched hand. Like it is the absolute reality of orthopedics, and it's important to know what red flags you're looking for, what bedside tests you can do, and what some of the big things you might encounter are. So I think the next thing is all the references and some of the textbooks we used. So I appreciate everybody